Our next speaker is Dr. Charles Malpas. Dr. Malpas is a neuropsychologist at Royal Melbourne Hospital, and he will speak to us this afternoon on caring for your brain. Thanks very much, Charles.
Thank you very much, and thanks for the opportunity to talk. Can everyone hear me all right? And you can see my slides? Fantastic. Yep. So yes, I'm a neuropsychologist, and I thought I'd talk about caring for your brain, but mostly from a neurocognitive perspective, or how to think about improving cognitive function. This is, of course, the area that I know quite well, but I'm going to talk mainly about the sorts of things that I have in discussion with patients who ask me questions about these sorts of things and what they can do to improve cognitive function. I've got a little picture up there of a phrenology brain. I'm sure many of you are aware that many years ago, hopefully, people thought that different parts of the brain would grow according to certain personality characteristics, and this would leave particular bumps on the skull, and a phrenologist could come along and feel your skull and tell you whether or not you're a reflective person, or perhaps you're a very benevolent person or something. And of course, this is absolute pseudoscience. What's it doing here? Well, unfortunately, we still have to deal with these sorts of problems, as in people, often on the internet, but not always, who are very willing to try to offer advice, usually with a fee, and usually with the promise of some kind of miraculous cure for cognition, but really they don't often do very much at all except take our money. And so whenever we're talking about things to improve cognition, things to deal with cognitive impairment, we have to be very, very careful about the information that we're getting, especially on the internet. I'm sure that's not news to anybody, but it's always worth pointing out. And I'll talk a bit about that with a particular example later on. So I'm a clinical neuropsychologist by training, and I work mainly at the Royal Melbourne Hospital. I run a number of clinics there. And some of you may have encountered neuropsychologists, but some not. We're a bit of a rare breed sometimes. So neuropsychologists are specialists in the diagnosis and management of cognitive disorders. And so whenever there's a question of whether or not a patient has a cognitive disorder and its severity and its characteristics, the neuropsychologist is usually the best person to go to see if you can find one. The kind of specific questions that we get from other clinicians are things like, does the patient have a cognitive impairment? This often seems like a bit of a strange one. You would think that most people know if they have a cognitive impairment, or if they do have a cognitive impairment or they feel they have one, that they actually do in their brain. Actually, it's not that simple, unfortunately. Sometimes people can think they have an impairment and really believe that, but actually be quite normal for various reasons we can discuss later. And sometimes people cannot be aware that they have a cognitive impairment as well. So seeing a neuropsychologist for clear diagnosis can be very important. In particular, it's important to understand the specific kind of cognitive impairment that might be going along with the brain tumor. Cognition is not one thing. We have different cognitive functions, memory, language, and so on. And understanding what's working well and understanding what isn't working so well can help, in particular with rehabilitation and compensatory strategies. So it really does need to be, in terms of cognition, an individual approach with the individual patient. There are no shortcuts to that. Sometimes the question is whether or not the cognitive impairment, if there is one, is consistent with the known brain tumor, or is it suggestive of something else? And this particularly happens in patients who are older or have other risk factors for things like dementia. And sometimes someone might have had a brain tumor years ago and been doing quite well, but perceived perhaps over recent months that things are getting worse in memory or language or something of that nature. And one of the questions we can help answer is this to do with the brain tumor, or is it that there might be something else going on that could warrant treatment? Very commonly, the question of psychiatric disorder or mental health issues arises. And of course, having a neurological or neurosurgical condition doesn't immunize you against having psychiatric issues as well and mental health problems. And in fact, often they go together. And one of the questions we get very often is there a psychiatric disorder that is on the top of this? Is it contributing in some way, or is it causing cognitive dysfunction? And most importantly, of course, what management or treatment is best for this patient from a cognitive perspective, and cognitive rehabilitation and the kind of rehabilitation that might be appropriate is of course one question, but also what other treatments or management strategies might be important. Should this person go and see a clinical psychologist or a sleep physician or a pain physician, for example, to help with their cognition? And sometimes the question is, can this patient make decisions by themselves? Sometimes, unfortunately, cognitive impairment can cause some difficulties with decision making, and we have an important role in protecting patients' rights to help them make their own decision if they can, or to find the best way forward for them to make those decisions. Our clinic, like many clinics in a public hospital, we have a consultant neuropsychologist, which is me, meant to be running the whole thing, trying to keep it going. But we also have another number of other clinicians, neuropsychology fellows, so neuropsychologists in their 7th, 8th and 9th year of training will be working in our clinic. And if you come into a clinic, that's probably the first person you'll see. We also have a neuropsychiatry fellow in some of our clinics now, the Royal Melbourne, just really emphasising that overlap between cognitive symptoms and mental health or psychiatric symptoms. And of course, neuropsychology interns, so trainees at earlier stages of their pathway to becoming a neuropsychologist. When we talk about cognitive impairment, we're talking about a lot of different things, and it will be different for every patient. And of course, some patients might not have any at all. But we're talking about difficulty with speech and language, so difficulty speaking, understanding, reading and writing. Difficulty sometimes with visuospatial functions, so seeing things, processing visual information, driving and navigating through the world, very common with some patients that have difficulty with that, finding things in space. The executive functions, which it would be a topic all of its own, but things such as planning behavior for the future, organizing things, getting motivated, and social cognition, so engaging in social situations with others. And of course, problems with memory, which is probably the main reason people come to see us, because they're worried that they're losing the ability to remember things, encode new information, recall it later on. And as I said before, whether or not a patient has one of these things or multiple or different is unique virtually for every patient and requires a unique level approach. What causes cognitive impairment? Well, the main thing really is the location of the tumour. That's going to be probably the most proximal factor that determines what kind, if any, of cognitive impairment the patient might have. And there are some general rules to this, but they're only general rules really. So I've just put a bit of a cartoon of a brain there. But if you have some sort of abnormality in the parietal lobe, you might have problems with language, with reading or writing, or with some aspects of attention. For patients with tumours in the frontal lobes, it can be quite complex, but this is typically where you would see impairments in executive function. So planning, motivation, apathy, and so on. In the occipital lobes at the back of the brain, quite often associated with vision impairments or visual perception impairments. And within the temporal lobes, very often language and some aspects of attention, but also memory. So these are sorts of general rules that we use, but again, really it has to be a patient-specific approach, because you could have two patients who have exactly the same tumour location, it looks identical. One will have a memory problem and one won't notice any memory problems at all. So this kind of variability is actually quite normal. The size of the tumour will have a big effect as well on cognition, and also the kinds of treatment that have been performed. So surgical treatments, radiotherapy, and chemotherapy and other treatments all have different effects and can, in their own right, cause cognitive impairment too. So I know I'm going to sound like a broken record, but really every patient needs to be treated individually to understand if there is any cognitive impairment and what kind of cognitive impairment there is. What can we do about these? And I think it's important here to think about impairments being primary, that is related to the tumour itself, or secondary, which is related to other things. I'm going to talk about secondary impairments a lot in just a moment, because they're the ones that are often a bit easier to do something about. So what can we do about primary impairments? Well, of course, the first thing is treatment. And the treatment itself, the kind of treatment, will often determine whether primary impairments improve or change over time. As a neuropsychologist, that's not really what we're involved with, but it's an important factor to take into account. The most important thing when we see patients, especially in the early days and especially after something like surgery, is we say wait. Quite often, especially after surgery or radiotherapy, cognitive impairment can be worse, but it can recover over time and sometimes quite quickly. So trying to be patient as much as possible is very important. Allow the brain time to recover and to heal. So quite often, if a patient comes to us, say in the first weeks or months following some kind of intervention, we'll often won't examine their cognition at that point, because that really doesn't serve much purpose. It can be distressing in its own right. And we know that quite possibly in the next couple of months, things would look very different. So waiting, giving treatment time to work. Very often we see patients who are contemplating going back to work. Or to some sort of function or some sort of occupation. One of the most important things we think is doing that gradually. It's very normal to want to go back and to engage in cognitive tasks such as complex work, care responsibilities, and so on, very, very quickly. But that has to be done in what we say a graded manner. So gradually over time, and that could be weeks to months. So you might go back to work, perhaps half a day at a time or for a few hours at a time, allowing yourself time to rest and recover. That's important because if there is any residual cognitive impairment, you need time to get used to that and to work out ways of dealing with it. But one of the things that we're very aware of is what we call adjustment disorders or neurocognitive adjustment disorders. And this often happens when people have some sort of treatment, they want to go right back to work straight away. They think they're going to be able to do very, very well, but then they get to work and they realize they're actually not up to it cognitively. And then they form the view in their mind that they're broken and that they'll be like this forever. And that is a big concern because it's very hard sometimes to shift that belief once it forms. Whereas if a patient goes back to work slowly and gradually over time, quite often we can avoid that, allowing yourself to build up very slowly to it. So gradual return to work is very, very important. And when we say to patients about return to work, if you're feeling frustrated because it's not happening quick enough, that's probably about the right speed. If you're not feeling frustrated, you're probably going back a little bit too fast, and you've got to be careful with that. Cognitive strategies can be very useful to help with primary cognitive impairments. And the specific strategies that might help will depend on the specific kinds of impairment. So quite often we see patients who come in and they tell us that they're very worried about their memory. They're unable to remember, say, conversations or things they've read. When we examine them, we find that their memory is actually quite normal, but their attention isn't functioning very well. So our attentional system is what allows us to filter out information in the world and focus on what we need to. And so if the attentional system isn't working very well, there's no way the memory system can work well because the information never gets in. And so the strategies in that situation would be to reduce attentional demands on cognition. So things like ensuring you're working in a quiet environment, ensuring you're working at one thing at a time, working in chunks of time for 15 minutes and so on. And these, of course, are very general ideas, but the idea is that you cater for the individual, yet they're tailored to the specific individual. Sometimes modifying the environment is necessary to help with primary cognitive impairment. So these will be things such as using alarms, calendars, and other devices quite often to help compensate for cognitive impairment. And sometimes that will be very a big change for the individual. It's something like having a large calendar on the wall with all the upcoming appointments, things like that. Sometimes smaller things. So in people who go back to work, the biggest advice we always give about modifying the environment is if you've got 2 screens on your desk and you've been working a lot using that method, you have 1 screen from now on and you have 1 thing that you're doing at a time. It can make a huge difference to cognitive function. The biggest, well, I suppose another very important one is the idea of self-compassion. Sometimes when we see patients in clinic, the patient will be very frustrated with their cognitive function, and that's natural, of course. And they really will be kicking themselves when they can't remember a word or they can't get a sentence out or something. And that's absolutely understandable. The problem with that is that when you get frustrated and you want to kick yourself, that actually makes the cognitive dysfunction worse quite often. And so you have to have a bit of self-compassion. You've got to stop kicking yourself. And quite often we point out to patients that they're treating themselves much more harshly than they would treat somebody else that they cared for in the same situation. Always very easy for me to say to somebody, I'm not that naive, but it's something to keep in mind, that self-compassion can go a long way into actually improving cognitive function. They were the sort of primary causes of cognitive dysfunction, but there are a lot of secondary causes that are very, very important. Most of these are common sense, and we know these are good things to sort of avoid anyway, but poor sleep affects our cognition no matter who you are, but it particularly affects your cognition if you've had something like a brain tumor. It has huge effects. And one night of poor sleep can be the equivalent of getting up and getting into your car after having one beer. It really is that significant. And people who have chronically poor or disrupted sleep will have chronically poor and disrupted cognitive function. Fatigue is a very, very important one as well. We've already spoken about that today. This is just from some data that we collected on patients recently. But the more fatigued that you are, the more cognitive impairment you will have. And again, that's for anybody, let alone if you've had something like a brain tumor or some kind of neurological event. So being aware that fatigue management serves a very, very important purpose in maintaining cognitive function. Depression and anxiety. So depression and anxiety can be caused by cognitive impairment, but it can cause cognitive impairment too. And one of the most robust findings we always find when we look at cognitive function is that depression and anxiety would reduce cognitive function. The good thing is that depression and anxiety can be treated. So it's an opportunity to address that. Seizures as well. So quite often we see patients in clinic who are having seizures. Now, not always overt seizures that are very evident, but sometimes what are called subclinical seizures, or seizures that might not be so obvious or that might be only happening at night. Seizures have long and prolonged effects on cognition. So somebody who's having one seizure perhaps every week at night, we would expect to still see some kind of cognitive dysfunction, perhaps not every day, but certainly in the day or days following the seizure. Again, that's something that can be readily treatable. And pain as well. I can't tell you the number of times we've seen a patient who's come in from neurology for something else, but also has migraines or headache of some kind. And alongside that, we'll have a cognitive impairment, because when you're in pain, you will not have normal cognitive function. In fact, that's probably the purpose of pain, is to direct our attention away from other things and onto the thing that might be causing the pain. And quite often, treatment of the headache or migraine or wherever the pain might be has a huge effect on cognitive function. It's always a bit of a balancing act, though, because treatments for pain, including medical treatments, it can also cause cognitive dysfunction. So it needs to be managed carefully, but quite often, that's an important thing to consider. And so what do we do about those secondary cause of cognitive dysfunction? Firstly, optimizing sleep. So in some patients, that would be referral to a sleep physician for investigation of what might be an unrecognized sleep disorder, something like obstructive sleep apnea, for example. But for many people, that might involve going to perhaps a clinical psychologist or a sleep psychologist to work on some strategies to improve sleep, what's often referred to as maintaining good sleep hygiene. The hygiene is a bad word. It doesn't mean what we normally think of. It just means good sleep practices. Things, for example, avoiding white light before bed, not going to bed with a device or a phone where you're looking at websites and social media and things like that until late into the evening, things of that nature. Understanding and managing your fatigue, and that really means a personalized approach, because people are fatigued by different things and in different ways. So people can get physical fatigue or cognitive fatigue or other kinds of fatigue. Understanding what triggers that and working to manage that as much as possible. And I'll talk about some professionals that can help with this later on, but again, clinical psychologists, occupational therapists, rehab physicians can assist in understanding and managing fatigue. One of the most easy things to do in this regard is to keep a diary or a log of when you are feeling fatigued and what might trigger that. And that can help identify strategies to reduce it. Treating low mood and anxiety is one of the easiest things to actually start to do. That can begin with a discussion with your GP, and referral to a clinical psychologist via a mental health care plan means that you can get Medicare rebates for that. So it's relatively easy to do. It can be difficult to find a clinical psychologist at the moment, but getting that ball rolling is relatively straightforward. Managing seizures if they're relevant to you, or identifying if they're happening. And of course, managing pain. So again, clinical psychologists can help with that, but probably pain specialists or GPs are a good place to go as well. And some general strategies for cognition that apply to everybody, of course, exercise. So physical exercise is very important for cognition in the moment, but also for maintaining good cognitive health in the long term. And that applies to anybody. Maintaining a healthy weight as well. So unfortunately, relevant to many of us during COVID, we tend to put on a bit of weight, but long-term obesity in particular is very bad for cognition. And so maintaining healthy weight, diet, and so on, very important. Don't smoke and try not to drink alcohol. So of course, cigarette smoking is a risk factor for many diseases, but it's an independent risk factor for cognitive impairment. For a number of reasons, but also because it reduces your ability to engage in physical activity. Drinking alcohol, unfortunately, is something that we should probably be avoiding as much as possible. But for anybody who's had some kind of neuro-oncological, neurosurgical, or neurological event, even more important, alcohol really is not good for cognition. Socializing, recently, social neuroscience, the evidence is mounting that socializing, engaging with other people as much as possible is one of the most important things you can do for your brain. It reduces the risk of things such as dementia. So the more social you are, the more engaged you are as much as possible, the better you'll do cognitively. A big question that we often get is around brain training. And, unfortunately, this is a bit of a difficult one because they are pushed very heavily by commercial companies. Brain training is, things such as lumosity, those kinds of things that promise to improve your cognitive function if you just go and play some games online every day. The evidence is relatively clear at this point. It's been investigated a lot. And the evidence is that it probably doesn't help. And I've just put up a quote here from a recent systematic review and meta-analysis of that. Brain training programs are sometimes good for enjoyment or entertainment purposes, but there really isn't much evidence that they can help improve your memory or general cognitive functioning. In fact, in many patients, it can have the opposite effect. So if you're someone who's worried about your cognition and you think there might be something wrong, doing cognitive tests over and over again online or on a computer that keep telling you that your memory isn't as good as it could be doesn't help your memory get any better. And really the best way, if you want to get better at doing work or socializing or reading books or whatever it is you want to return to, the best thing to do is practice doing that thing. There aren't really any shortcuts from brain training, unfortunately. If you are going to do brain training, be aware of these things and try and choose one that's free so you don't have to provide your credit card and pay for something that might not be very good for you. Who are the professionals who can help with cognition? Well, of course, general practitioner, neurosurgeon, your neurologist are the first people to talk to. Neuropsychologists for diagnosis and management of cognitive impairment. Hard to find sometimes, but worth a try. Clinical psychologists for management of mood and sometimes sleep and fatigue. So always worth talking to your general practitioner about a referral to a clinical psychologist on a mental health care plan so you don't have to pay the full fee. Occupational therapist, absolutely essential for returning to things in the community, including cognition. Speech therapists, of course, for speech and language impairment. There are a number of strategies that you can use to improve in that regard. And exercise physiologists, a relatively new profession that's become very relevant in the post-COVID world. But in terms of improving your fatigue and physical function, exercise physiologists are very, very good at that and help people work towards those goals. People often ask about clinical neuropsychology services, how to get them. This, unfortunately, is a very Victorian specific slide. However, the best place to go if you can't get access through your treating hospital is to a university clinic. So the University of Melbourne Clinic, for example, offers highly subsidised neuropsychological services in a private care model. It's a training clinic, so you'll be seen by a consultant, but also by trainees, but a very high quality standard of care and very heavily subsidised. If you're not in Victoria, it's quite possible that universities in your state who offer neuropsychology training programs would run similar clinics. So worth a try, and don't be concerned about getting some, because it's trainees in the clinic, you won't get the best treatment. we have trainees in the hospital as well. You'll be getting very, very good treatment and diagnosis from those services. That's all I really wanted to say, but I'd be very, very happy to answer any questions, especially if I've sort of misjudged what I needed to talk about, and if you've got anything specifically that I can help with.